Good morning, everyone. My task this morning is to update you on where we are with ACL repair. I want to thank Reinhold and everyone at ARTHREX for allowing me to share my data. My name is Gregory S. I'm from the Hospital for Special Surgery in New York City. My first ACL repair I did in 2008, and it's been quite a long and winding road since then. This is one of the earlier papers that we wrote where we suggested that maybe the orthopedic community abandoned the idea of ACL repair a little too soon. It seemed to me that the previous generation of surgeons had the right idea, but simply the wrong execution. Imagine, if you would, if we stopped innovating with the cell phones after this gem. We'd never end up where we are today with supercomputers in our pockets. Those of you with teenagers actually might enjoy that. My idea was simple, that the ACL tear on the left behaves differently than the ACL tear on the right. And we were all taught that the ACL can't heal because it has poor blood supply. This is an acute proximal ACL tear in a 40-year-old martial artist, and you can see very well that there's excellent blood supply by looking at the capillary refill. This is a proximal type 1 tear, one of my earlier cases in my first 20, and you can see that it was off the wall there. This is the perfect tear to do ACL primary repair with internal brace, and here you can see a year later how the ACL's healed nicely. Most impressively, if you look at the origin of the ligament up by the femoral wall, you can see it's healed very readily to the wall, and if you look closely, you can see the internal brace under the scar tissue there. This patient's about 8 years out and has had no issues since. Basically, I'm suggesting that ACL reconstruction, we should have more arrows in our quiver than ACL reconstruction. I want to share with you my research, give you a little idea of where I think the future of ACL surgery is going to be, and we'll go from there. Over the past decade, the interest in ACL primary repair has really skyrocketed, as you can see here from the number of publications per year. There's about 4 techniques out there that are in the mainstream. On the upper left is my suture anchor technique, to which I added the internal brace right around when it came out, actually. On the upper right is Gordon Mackay's technique of internally bracing using buttons. This was also studied by Dewigi and Wilson. On the lower left is the DIS or ligamus technique, and this one has quite a bit of data on it where they bury a large spring into the tibia to introduce some give into the system. And on the lower right is Martha Murray's technique, where she places a blood-soaked collagen sponge in between the ends of the ligament to try and help the healing. That's the Bear technique. In the past 18 months or so, there's been no less than 10 systematic reviews on ACL primary repair, indicating the spiking interest across the world. I'll go through one of them. This was a paper that my team put out, looking at papers from 2014 to 19. We looked at 13 studies, 1,100 patients, and we specifically looked at selective surgery done for proximal tears, only arthroscopic primary repairs. We split the groups into 3 groups: non-augmented primary repair, which would just be the suture anchor repair, static augmented repairs, which would be the internally braced repairs, and dynamic augmented repairs, which would be the ligaments data. All of the functional outcomes were over 85, and the failure and reoperation rates varied by type. Our conclusions were that the outcomes were promising, but as with all nascent techniques, we need better data. Here you can see the failure rates with really not much difference between the 3 techniques. However, there is a big difference when you look at the reoperation and the removal of hardwares, and the ligaments data with the spring had nearly 40% of their patients require removal of hardwares and reoperations. I am encouraged to say that the internal brace numbers, when we wrote that first paper, was only about 60 patients that had been published upon. And now we're preparing another systematic review only on internally braced patients, and the results are very encouraging with over 400 cases that have been published upon. We'll quickly go to my technique. Suture anchor repair has a lot of benefits. It's simple, intuitive, and it works. It's technically straightforward and minimally invasive. It's really like a rotator cuff repair in the knee. I use biologically vented anchors, one high and one low, to restore the whole footprint. Its fixation point is appropriately at the bony origin, and if it happens to fail, it's very easily converted to a reconstruction. Technique's been published in Arthroscopy Techniques. My overall approach to ACL surgery is what I call ACL preservation. This has also been published upon. It's a treatment algorithm that's based upon tear location and tissue quality. I base everything I do off of the remnants. We've modified Sherman's classification system. For the types 1 and 2 are in the proximal 25% of the ligament. If I have excellent remnant, I'm going to go straight with the primary repair, although I use internal brace for all of these now. If I have an okay remnant but I can't quite reach the wall, I'll primarily repair the remnant to avoid cyclops and then augment it with the graft. And finally, if there's very poor tissue, I'll just go with the reconstruction. These are some examples of patients that I would repair, augment, and then reconstruct. We looked at 361 ACL patients, of which I was able to repair 44% of them. And what we found was that age over 35 had a 4 times odds ratio of being predictive of repair. Surgery within a month, 3 times odds ratio, and also a low BMI. We specifically focus on the type 1 and 2 tears, as I mentioned. The number 1s are within 10% of the length of the ligament to the wall, and the 2s are from 10 to 25%, with 3s being mid-substance. We've also published in the pediatric group. This varies by age, with the youngsters at 6 to 10 having much more bony avulsions, and then once the physes close, it assumes the distribution of the adults. This paper looked at the MRI remnant length and showed that if the remnant on the tibial side, the distal remnant was over 75% of the length of the ACL, we were able to repair those patients 94% of the time. My results, we looked at the first 11 patients at 2 and 5 years. That was kind of the proof of concept papers showing excellent results. This paper came out in 2019 on 56 patients. About half of the patients were with the internal brace and half without. It was a bit underpowered to determine whether the brace made the big difference, but suffice it to say that the patients did very well and there was no significant difference in failure rates. Our most recent paper was the first time we were able to divide the outcomes by age group, and the results were very telling. We had 113 patients. The largest group was over 35 years of age, 60 of those patients, 2 failures or 3% failure rate. Between 22 and 35, we had a 4% failure rate, but under 21, we noticed we had a 37% failure rate, and this has led me to adjust my indications in the youngest patients. This paper recently came out, acute versus chronic. We looked at 32 patients less than 3 weeks, 34 patients at 164 days, and we found that there was essentially no differences in outcomes, which kind of changes the algorithm such that the most important detail is the tissue, tear type and tissue quality, and not the time since injury. You can see here on the low right, dissecting the ACL off of the PCL, and there were no differences in failure, reoperation, complication, or contralaterals. I've done over 375 patients thus far, up to 12-year follow-up, running at around 90% clinical success rate, and I try and focus again on the 1s and 2s. Return to sport is very, very similar to ACL reconstruction. This paper was published in the knee last year. Tegner activity levels, return to any sport 85%, knee strenuous sports 70%, and the pre-injuries was 60%. And that's the teenagers are baked in there. Most importantly here, you can notice that almost 40% of the patients got back to sport within 6 months. Joint awareness, I really like this paper. We published it in March 2020. Not many people are aware of the forgotten joint score, but really it shows and assesses how many times people think about their knee. And what you find is that the people who have ACL reconstructions are constantly thinking about their knee, and the people who had primary repairs rarely think about their knee. There's dramatically decreased morbidity. You can see this patient, 24 hours, no blocks, no pain. He's about 5 years out now. This patient, 6 weeks, looking like this. 3 months, she ran a half marathon, scored 70th out of 3,000 people. This patient, 4 months, back to nationally competitive tumbling. And finally, this one, which is quite amazing. She's 4 months out from simultaneous bilateral ACL repairs. She took a heck of a tumble skiing and tore both of her ACLs at once. The big thing we've got now is ARTHREX has released the primary repair, the Swivel Lock ACL primary repair kit, and this has all of the tools that surgeons will need to help them to perform this surgery seamlessly for your patients. So we suggest that you think outside the box, that we don't just have a one-size-fits-all approach to ACL surgery, and repair may have a position in your toolbox for certain patients. The tear on the left definitely behaves differently than the tear on the right, and it seems intuitive at this point. ACL repair with internal brace using the swivel lock techniques works great. I've worked out the details over the past 12 years, and I've shared them with many technique videos and quite a bit of data on the ARTHREX website. I believe we should all have a multifaceted approach to ACL surgery. We should have many tools in our toolbox. ACL repair is a low-risk, high-reward surgery. Essentially, we're picking the low-hanging fruit off of the ACL tree. What we want to avoid, however, is the chasm of disillusionment. And with any early innovations, you have the innovators, the early adopters, and as people jump on board to try this neat new technique, their indications aren't quite as tight and their technique's not quite as good, and so we see a lot of failures. That's where ARTHREX is so great in helping to educate us all, and I think everyone should partake in all of the knowledge on the website. So the goals are to fan the discussion regarding ACL repair surgery. Judging from this ESCA survey we just did, it seems that we're succeeding. Is ACL repair a reasonable surgery for appropriately selected patients? 70% of the people surveyed agreed that it was. So I believe that the future is going in this direction where within another decade or two we're going to have graftless ACL surgery without question, trying to make things better for our patients. If you want to avail yourself of this technique, first you have to change your workflow, look inside the knee before you get going. You can't go with an ACL repair if you've already taken the graft. Do cadaver labs to practice the procedure, practice stitching the ACL prior to removing it for recon, work up to repair, start with the older population, and persist through your learning curve like you did with a rotator cuff repair in the shoulder. Thanks to my research team, and again, thanks to ARTHREX for having me.